Okay. Hi everyone, thank you for attending to this event and thank you for your invitation. My name is Anis Krache. I have a master's degree in pharmacokinetics and in this presentation I will show you a part of my work and it's called Preclinical Pharmacokinetic and Dosimetry of a Zirconium antigen-labeled antibody in an orthotopic lung cancer murine model. So this is a PhD, so there is 3 collaborating teams. CRCT with directed by Etienne Chatelou, dose individualization of anti-cancer drug, TONIC, Toulouse Neuroimaging Center, which stands to develop in the biomarker development of radiolabeled molecules, and Zynexa, which is an industrial part, take place in trying to give radiolabeled molecules for biomarker technology. So my presentation is about lung cancer. Lung cancer is a world deadly disease with 2.2 million cases in 2002 and 1.8 million deaths. And as you can see here in the graph, it's a second incidence behind breast cancer with 11.4% of all cancer disease. About the overall survival, if you can see here, I just try to summarize in the 4 stages. At stage 1, we have 71 to 89% of pulmonary of overall survival, and the treatment is pulmonary lobectomy. And if we see at stage 4, we have 6% overall survival at 5 years, and the treatment is chemotherapy or targeted therapy like immunotherapy. And according to World Health Organization, in 2015, 70% of the diagnosed lung cancer are at stage 3 and stage 4. So they're advanced, and that's what could explain the amount of death according to lung cancer. Now let's just try to introduce immunotherapy and how it works. And as discussed earlier, immunotherapy consists in targeting specific molecule induced by a therapeutic effect. Treatment is also administered according also to PDL1 or, for example, PDL1 expression cell in according to for immunotherapy treatment. And it first, when there is a connection between tumoral cells or APC, which are antigen-presenting cells, there will be first response, and there will be a immune therapy. There will be a immune response from the immune system. But with that in mind, immune cells are also subject to inhibitory signals in order to maintain the homeostasis of the immune response. So those inhibitory signals can be expressed by PDL1, for example, or PD1, and will induce inhibition of the immune system. And for example, anti-PD1 and anti-PDL1 therapy, their role, it will be to block this PD1, PDL1 response, and in order to to restore this immune response. And patients mostly are selected using PDL1 expression. But other patients with PDL1 negative expression shows good response to also response to PDL1 expression. It depends on how. It depends on. Sorry, I just lost my word. But it depends on how some negative patients also demonstrate benefits from the immunotherapy treatment. It depends, on how you extract your immunohistochemistry, and whether you do it on metastasis site or you do it on primary site. We can have this PDL1 expression could vary. So there is an increased need for us to develop biomarkers, and what we think that we can develop molecular imaging in order to assess PD1 expression, in order to assess patient criteria eligibility. within that set and fantastic results of immunotherapy, some patients failed and tend to resist to immunotherapy. So Sharma and all summarize that in three forms of resistance. The first one is the primary resistance, where cancer does not respond to any immunotherapy strategy. The adaptive one, when the cancer cell is recognized and then the immune system protects itself by adapting to this immune attack. And the acquired one, which clinically patients respond to the treatment, but they fail, they relapse after a period of time. And if we focus on the PD-1 immunotherapy, 15 to 25% of treated anti-PD-1 patients with anti-PD-1 treatment in non-small lung cancer, they tend to develop immune resistance. So a team from Kayoma and all tried to investigate why that resistance could appear. And so they tried to see in team 3, which is a team T immune globulin mucin 3, and they tried to see if it's upregulated or downregulated during PD-1 treatment. And what they see here in the graph, you can see that when they administer PD-1 treatment, they will have team 3 positive expressing cells that will increase along this PD-1 treatment. So that could be a lead of immune resistance during anti-PD-1 or anti-PDL1 therapy. So the objective of this presentation is just to analyze the pharmacokinetic of an anti-PDL1 labeled with zirconium-89 and to be able to see if we can correctly visualize first the tumor by if also it expresses PDL1, and also to give you an idea about how we can do that and the results we have by this end. And also, since we're going to use nuclear imaging, there is radio protection concern about that. So we will need to evaluate the dosimetry of or the exposure to this radiation in mice, and then try to predict that in clinic in order to see if we can use this radiolabeled zirconium-89. So the first step is the anti-PDL1 radiolabeling. So it's a simple method to do. You just need to inject your chelator, which is a cage called PNCS benzene DFO. It's derived from deferoxamine. You will just have to incubate it with anti-PDL1, and after a small step of chelation, you will just put it in incubation with zirconium-89, and then you will have your magic. Here, well, the magic occurs, and you will have a radiolabeled compound. And in third step, you will just have to purify it in order to have this anti-PDL1 DFO radiolabeled with zirconium-89. And so after this small purification, so we are good to go to try and to examine our anti-PDL1. So we performed some in vitro assay, and in order to see if there is no damage for our done to our antibody. And so what we have done is that we incubated in CMT 166 cells, which are derived from lung murine cell, lung cancer murine cells. And we try to investigate the immunoreactivity and the in vitro specific binding. And here we can see that immunoreactivity was quite good. We have 96%, and we compared to the literature, which was also a good result. And also we performed the binding. We find a binding of about 5.6 nanomolar, and we are in the scope of the range of antibodies used in therapy. And so we have proved that using that method, our antibody is not damaged. And so we maybe could and can apply this method, this radiolabeling procedure to other immunoglobulin, for example, anti-TIM3 or maybe anti-PD-1. So we are here good to go for in vivo experiments. And so that was image from last year, and we're really excited about it because we first injected in healthy mice, because we use also a immune anti-PDL1, a murine, sorry, anti-PDL1, and so here we assess the first biodistribution in healthy mice. We can see here we have the overall same expression for all antibodies. We have a huge concentration at first day in the liver, which is also the proteolytic state of elimination also of the anti-PDL1, and also we have in the lungs a really low noise, which is very good for us because we will tend to have a higher SNR in order to use it for diagnosis here. And so we also performed that in vivo biodistribution in tumoral mice, and here, as you can see, we were successfully able to target PDL1, and as a proof of concept, we will use that anti-PDL1 in order to track the tumor in the whole body and maybe have a mapping of whole body anti-PDL1, whole body PDL1, sorry. And it exhibits the same concentration in the liver and tends to diminish over time, but as we can see here, the signal keeps within the whole week of image. We also tried to analyze the SNR in order to find the best time imaging, and we found that the SNR keep increasing because, as again, the signal in the lungs will diminish, and we will have a higher SNR with that time. We also try to compare between both of them in order to see the biodistribution, if there is any differences between both of them. As we can see here in the healthy mice, there is no differences except in the liver, which is more higher here in the tumoral one, and in the bone we have less activity, but this could be of the product of degradation of our antibody, because when it is degraded, we will have free zirconium in the body, and since our mice are really young, they will have a high reforming and remodeling, bone remodeling, sorry, and this high bone remodeling will increase the uptake in the bones. And here we can see the tumoral, also the tumoral concentration, which is near to the level we have in the liver. And also, so we try to understand this kinetic in order to be able to have both concentration and SNR, and in order to find the best time imaging. So we compared SNR and also the time activity curve within the tumor, and we see that we have successfully targeted the tumor within 24 hours, and also we can see here at 24 hours that the concentration keep increasing to 48 hours, and which is day 2, but there is also a high variability, and this signal tend to diminish over time. So the Cmax, so the maximum concentration, was at 48 hours, and according to the SNR and the image quality, we think that 48 hours could be the best time imaging. This idea of searching of the best time imaging is crucial for us because we will have, for example, if we tend to develop that for clinical development, we can say that we inject the patient day 1, and then we will have like 3 or 4 days in order to estimate the SNR, or also to estimate the PD-1 expression. So this parameter is very important for us in order to being able to realize a good imaging. And so also we try to perform the pharmacokinetic of zirconium-89. So we use 2 methodology analysis. We use a non-compartmental analysis and a compartmental analysis one. So the NCA1 is based on a trapezoidal method or moment method, and to estimate blood and organ parameters, and compartmental one, which is a model-based analysis in order to estimate blood also and organ parameters, and also for dosimetry application. So those results, both of these analysis, one will try to confirm the compartmental one for using method, and also to be able to correctly estimate the dosimetry. And so we try to compare between, in the blood, both of our PK parameters. We see that we have no difference between both of them, except in the volume of distribution and here in the half-life time. And we can also see that there is there is a higher variability in the tumoral mice than in the healthy ones. Also, if one of our hypotheses is that the tumoral mice could have a higher variability because there is an induced tumor. And when we see on the CT scans of this tumor, we have a huge variability. We can have a larger tumor. Maybe tumor could express more PDL1, and so depending on those factors, we can have that could explain this variability we can observe here in the tumoral imaging and also in the blood. We also try to perform the AUC of organs in order to compare between both of them, and as we can see, and according to the biodistribution, we found a difference between bone uptake and the liver uptake between healthy and lung cancer grafted mice. This NCA results will be used in order to confirm that our PK model will be robust enough in order to perform dosimetry calculation. So that's what we did here in order to compare the experimental points. We use a one compartment model in order to estimate AUC, and the one compartment model will captured correctly the observed data, and then we compared those AUC between the model-based and the compartmental one, and compared to the RMSE, which is the root mean square error, and we found that we have a good RMSE, and that, with it that said, that one PK model could be used in order to estimate dosimetry. So this is what does look like for dosimetry. We have experimental data. We will do a translational from experimental data to organ data using Mark-Paland equation. So which is shown here in the table, in order to estimate correctly the absorbed radiation per organ. And if we try to focus on the effective dose here, according to the ECPR, which is the guidelines for radioprotection, we have a dosimetry of 0.06 milligram per megabecquerel, which could be also used at 60 microsieverts per megabecquerel. This is really interesting because in comparison with other with FDG, we are only like twofold higher than FDG. And what is also interesting in this part, it's because anti-PDL1 are specific to the tumor, we can inject less activity in order to observe the tumor. And so these results could lead to a clinical practice and maybe a clinical translation in order to use it in clinic, and also to assess PDL1 expression in the clinic. So in conclusion, we were successfully validated the model, and all the tumors were visible on the CT. We have no damage to the anti-PDL1, and we successfully radiolabeled. We tried on other antibodies, but I didn't show the data here. For example, on TIM3, and we also successfully radiolabeled the molecule, and we had also good results according to the radiolabeling. For the biodistribution, we saw that we have a low length background signal, which is good because it will increase the SNR, and the tumor was also visible within 24 hours, so within day one. Maybe it could be visible less than day one, but we prefer that we use that. We prefer to use this image at 24 hours or to 2 days after injection. Sorry, I did a mistake here. It's not 72, it's 48 hours. And for dosimetry application, we have an effective dose about 60 microsievert per megabecquerel, which is very good for our results. And with that low dosimetry, maybe it will be suitable for human dose. Thank you for your listening. And if you have questions, I will be happy to understand.